hospitals. It is a learning opportunity for all the students, fellows, and practicing ophthalmologists to brush up their knowledge. Today, our DNB residents, Dr. Vaishali and Dr. Manisha, will present their cases. I welcome and thank Dr. Sahil Agarwal and Dr. Swati for giving their valuable time for this teaching initiative. I now hand over the mic to Dr. Ayushi to introduce our guest faculty and also to take us through the sequence of the events.
Thank you, Dr. Nidhi and Dr. Saurabh, for giving me this wonderful opportunity to moderate and co-organize this wonderful session. Today, we have two renowned speakers who do not need any introduction and will be enlightening us on pediatric proptosis and pediatric orbital tumors. So first, we have Dr. Sahil Agarwal today, who will be talking about the evaluation of proptosis and the pearls and the pitfalls. He is currently the assistant professor in the Department of Ophthalmic Plastic Aesthetics and Ocular Oncology Services at the RP Center, AIMS, New Delhi. He has done his junior residency and subspecialty training from AIMS and has more than 60 PubMed Index publications. He has won several awards, including American Academy of Ophthalmology Award, awards at the World Ophthalmology Congress, at the Korea, Japan Ophthalmology Congress as well, and is a peer reviewer of several PubMed indexed journals, including the prestigious journals like OPRS and Orbit. He is also the assistant editor at the BMC Spring Nature and is also the subspecialty editor of several journals. His key areas of interest include eyelid and periocular aesthetics. We then have Dr. Swati Kaliki, who's an internationally renowned surgeon. She heads the Department of Ophthalmic Plastic and Facial Aesthetic Surgery, Orbit and Ocular Oncology at LV Prasad Eye Institute, Hyderabad. She also heads the Operation Eyesight Universal Institute for Eye Cancer at LV Prasad Eye Institute across the network, and is also the adjunct professor at the University of Rochester, New York, USA. Following her fellowship in oculoplasty at LV Prasad, she went to Dr. Jerry Shields and Dr. Carol Shields at Wills Eye Institute, Philadelphia, for her training in ocular oncology. Not only that, she's also trained in ocular pathology with Dr. Ralph Eagle Jr. at Wills Eye Institute. She is one of the top 2% clinician scientists as per the recently released Stanford list of 2024, and has more than 368 publications and 300 conference lectures and several instruction courses. Recently, she also won the Ludwig von Salman Clinician Scientist Award at the prestigious ARVO, including several achievement awards at AAO and APAO. She also received the top 100 most influential ophthalmologists in Asia Pacific region award recently at AIS APAO. She is one of the key opinion leaders in the field of retinoblastoma, ocular surface squamous neoplasia, and sebaceous gland carcinoma globally, and is also credited with description of a novel entity, the nodular ulcerative OSSN. So I welcome both of you today for sharing your expertise with us, and we'll start with Dr. Sahil's talk today. Over to you, Dr. Sahil.
Thank you so much, Dr. Ayushi and Dr. Saurabh, sir, for having me over. I'll try sharing my... And I'm also glad on this auspicious day I'm able to present, besides this speaker, Dr. Swati ma'am was not just a compassionate clinician, but a true teacher and a leader. And without wasting any further time, so I'll dwell into proptosis. Proptosis is basically the forward displacement of the globe in relation to the skull. It is measured by the amount of protrusion that has happened in front of the outer orbital rim to the apex of the cornea. Any measurement of more than about 20 mm is taken as, on an absolute reading, is taken as proptosis, and a difference of 2 mm between the two eyes for an Asian and Caucasian population. Care should be taken to label all other globe prominences where there is no displacement as pseudoproptosis. The first one being unilateral high myopia, cases with ophthalmos, contralateral ptosis, which with the contralateral retraction, widely broad fractures where it's certainly in ophthalmos. However, we tend to find that the other eye might be a proptotic eye, but in all such cases, the other eye is generally in ophthalmic. Microphthalmos with cyst of a contralateral eye, and all shallow orbits. Care should also be taken not to label any cases of proptosis and interchangeably be used the word exophthalmos, which is mainly to labeled in cases with thyroid eye disease, or label all cases of craniosynostosis with shallow orbits as proptosis, because these are cases of exorbitism, and on the other hand, this is a case of a globe luxation. Right. So classification of proptosis again, it could vary from from studies. So we'll start with the region of onset. It could be a presentation right at birth in the first week of birth, presenting as an orbital teratoma. It could be a presentation at 1 or 2 months of age as a hiatus of the temporal bone presenting with encephalocellular meningeal, and it could be a relatively late from presentation with the capillary hemangioma in the orbit with a large proptosis. Presentation in the first decade of life could be an optic benign lesion like an optic nerve glioma or a dermoid cyst or a velar lymphatic malformation. And in the late, it could also be as a malignant lesion of a rhabdomyosarcoma, in this case, a typical extraocular retinoblastoma. The presentation could be unilateral, it could be a bilateral presentation. In cases of bilateral presentation, systemic involvement should be taken care of, and the differential should be thought in the same line. It could be cases with leukemia, neuroblastomas, and peanut tumors, also lymphoproliferative disorders present in the same way as bilateral presentation. The mode of onset could be hyperacute in all such cases of trauma. This child who presented to us with a tight orbit, fixed globe, and a globe which was quite spaced out. There is a periosteal and retrobulbar hemorrhage. Another presentation could be an acute to subacute cases and with orbital infections and in cases with rhabdomyosarcomas. The course of disease could be stationary, like in cases with optic nerve gliomas or orbital dermoid cysts. It could be rapidly progressive in cases with rhabdomyosarcomas or other malignancies that we know of in children. However, there can be also cases where the globe is initially stationary, like in cases of VLM. This child presented us with VLM, but after 6 months of presentation, he had a sudden bleed in the lymphatic malformation, and there was an acute presentation of the proptosis. So a stationary course to start with, and there is a sudden progression too. Based on the direction of proptosis, it could be an axial proptosis or an abaxial proptosis with both the visual axis in the same stationary plane. In all such cases, the masses are generally lying in the intracorneal space. For children, it could be an optic nerve glioma, optic nerve glioma sitting there, right? And for the adults, it could be a differential of thyroid eye disease, obviously. The proptosis could as well be an abaxial proptosis, wherein depending on the quadrant of involvement, for example, if it's in the superior quadrant, it could be a lectama gland tumor. In the superior nasal quadrant, it could be an encephalocellular meningeal, or in adults, it could be a frontal ciliate ethmoid mucocele. Nasally, it could be a ethmoid mucocele again, and lacrimal sac tumor originating inferior nasally. In the inferior orbit, it could be a synorbital mass, which is going inside the orbit, causing a proptosis in the abaxial proptosis happens in the quadrant opposite to the lesion that is present in a direction opposite to it. For example, if it's in the infranasal quadrant, proptosis happened, the abaxial proptosis, the lesion must be in the superior quadrant, temporal quadrant. Proptosis could also be classified on the basis of being pulsatile and non-pulsatile. The pulsations could be direct or indirect pulsations. Indirect pulsations in the case of, again, hiatus causing an encephalocellular meningeal from the CSF, or in cases of CCF, the direct pulsations could happen in highly vascular tumors, including those of angiosarcomas or hemangiocytomas. Depending on etiology, again, this pneumonia of VEIN, vascular, endocrine, inflammatory, and inflammatory, which could be infectious and non-infectious, along with neoplastic lesions, could be very well classified. I mean, ma'am would be discussing them in detail in the subsequent session. Coming to clinical workup always starts with history. As I've already discussed, the age of onset and course and the progression that happens is to be noted. Vision loss can always happen. It could be indicating a direct origination from the optic nerve sheath per se, or the optic nerve in case of the optic nerve glioma, or it could be because of compression from the surrounding over the optic nerve, as well as on the retina, causing a retinal detachment. Muscular involvement can lead to diplopia, and a tight compartment or with an orbital infection, there could be signs of inflammation, rubor, Keller, Dauber. Taking into account systemic history of the patient is again very important, and asking for any previous history of a known case of a neurofibromatosis, a thyroid eye disease, tuberculosis, trauma, malignancy becomes very important. Again, a very important history to be taken out is any history of hypothyroidism that the mother had during her pregnancy and at the time of delivery, where the transfer of factors have happened, transplantation leading to a congenital thyroid eye disease. Proptosis workup sheet becomes of quite handy to us. I mean, for all residents, this sheet becomes very important to know what is to be, I mean, they need to do it on a daily basis. And the same thing coming from inspection to palpation to auscultation, so that the same is indulged in the muscle memory, and even in a busy OPD setting, they do not miss on any of the differentials. So it starts with the general appearance of the face, wherein you look for any facial asymmetry. If at all present, it could be a case of ipsilateral venous lymphatic malformation, or a neurofibromatosis with a hypertrophy of the hemifacial space, or with an S-shaped ptosis. There could be a periorbital fullness along with periorbital ecchymotic changes, like a raccoon sizing and neuroblastoma, or it could just be an orbital cellulitis presenting with skin changes along with skin necrosis. It could be a globe dystropia, which is happening along with proptosis, and proptosis, which could be an axial and abaxial. Care should be taken to find out whether the proptosis is pulsatile or not. So this lady, this is an idea where there was a proptosis with the pulsation, which could be very well seen. Positional proptosis should also be taken into account by asking the patient to bend forward or do a Valsalva maneuver, wherein because of obstruction of the inferior vena cava, the return to the venous return decreases, and there happens orbital stagnation of the venous blood, causing an increase in size of the venous lesion or the increase in the proptosis. Then comes the eyelid. In cases of lid retraction or lid lag should be noted for canal TEDs. Ipsilateral edemas may indicate an underlying necrotizing fasciitis which can be setting in. And the conjunctival lesion should also be there can be localized congestions which could be present just at the insertion of the muscles, indicating TEDs. There could be dilated lymphatic vessels, indicating a direct VLM. These are the telltale signs which directly indicate the underlying lesions. A grayish or a violaceous lesion in the conjunctiva, again indicating a varices or underlying renal lymphatic malfunction there, or dilated episcleral vessels could be indicated for CCF. Looking at the cornea again becomes of quite importance. The SPKs might help in early treatment and thereby preventing an exposure keratopathy that can happen. Presence of lesion nodules indicates neurofibromatosis that should be taken care of. Any pupil examination should be done to look for RAPD and APD indicating any damage to the optic nerve. All cases of orbital cellulitis should have an extraocular muscle movement videoly documented on a daily basis so that the response to treatment can be noted very well. Fundus evaluation should definitely be done looking into the choroidal folds, localized RAD present or an occluded edema. Coming to palpation, any mass which is definitely there should be altogether palpated, know its extent, borders, temperature, tenderness, along with its consistency, its fixity, surrounding structures, or the underlying bone or the skin, and to look for any transformation tests which could be telling us that whether the mass is solid or cystic. On the other hand, if there is no mass which is palpable, a retropulsion obviously helps you out. Retropulsion is basically the thumbs placed over the closed eyelids, like in this case, and pressing against the globe. If there is a resistance to your push, that indicates that there is a mass which is probably sitting behind the globe, and therefore it is a positive retropulsion test. In anteorbital masses, which are just preseptal or have just crossed the septum, in all such cases, a deep palpation can be done. For a deep palpation, you ask the patient to look in the extremose down gaze and place your fingers in the upper just below the brow area. The septum is now taut, and you're placing your fingers against that taut septum. Once you ask the patient to look in the extreme up gaze, the septum unfolds, the septum becomes loose, and your finger insinuates. And that, with the tip of your palpable surface of the finger, you can very well feel and palpate the anterorbital masses. So, doing palpation care should also be taken to palpate the bony orbital rim. It could be tender, there could be irregularities of the bone due to bony erosions in cases of malignancies, or there could be scalloping present, which could be seen in cases with long-standing masses. Not to forget the regional lymph nodes, the preauricular lymph nodes, submandibular and the anterior cervical lymph nodes that should be palpated very, very well to look for any spread of the disease. Speaking about exophthalmometry, I mean, this is the main clinch point for all examination of proptosis in all cases, wherein you can do a subjective method, the Navziger's and the worm's eye view, wherein in Navziger's view, the clinician stands behind the patient and observes the patient's protuberance from above, taking into account the forehead as the plane of reference. And in a worm's eye view, the patient is asked to flex at 45 degrees, and the clinician then looks from infrared upwards, looking for the change in protuberance by taking the cheek as the reference frame. The same can also be done objectively by using a Hertel's exophthalmometer or a Lewis exophthalmometer. Lewis exophthalmometer basically is a oblong plastic graduated scale with a 40 mm of marking. Placed the lateral orbital rim gives you the amount of proptosis that is present. Hertel's exophthalmometer, on the other hand, is a calibrated bar with two carriers, a fixed carrier and a mobile carrier with two prism mirrors with red markings on it to prevent parallax formation. So what you need to do is you need to ask the patient to sit at your eye level, at the clinician's eye level, with the diffuse illumination coming overhead. You basically adjust for parallax to begin with. You place the arcs on the lateral orbital rim in line with the lateral canthus. The placement of the arc should be at the minimum amount of intercanthal distance, so that base should be noted. The base, the lateral separation should be noted, so that on every subsequent examinations, as it is a comparative form of exophthalmometry, You do not miss out on overdoing or underdoing the values on the scale. Once that is done, the parallax is now taken care by the two red markings which are present on both the mirrors. These two markings are allowed with one eye closed, are made to coincide with each other. Once these markings have coincided very well, so what you note is the apex of the corneal mark scale at the scale reading on the prism. So in the right eye, in this case, it is 12, in the left eye, it is 18 mm. So there is a difference of about 6 mm of proptosis. The same can also be done when the hurdles is not available using a simple ruler placed at the lateral orbital rim and looking for the amount of protuberance that the eye has. In cases with absence of lateral orbital rim, a Nogle's exophthalmometer is much of a help. Uses the forehead and the cheek prominences for placement. These are all for theoretical importance. The other exophthalmometers that are available. Again, in cases with abaxial proptosis, the hurdles doesn't work because it's mainly meant for anaxial proptosis cases. A radiographic method becomes of by the glal and trocal becomes much of importance. In a mid-orbital section, a line drawn all across the apex most point of the zygomatic processes, with a vertical line drawn from the apex of the cornea to this horizontal line gives the difference of the proptosis in both the eyes. Dystropia can also be measured subjectively by placement of a ruler to look for the vertical dystropia by placing a ruler at the forehead, and for the midline shift for the horizontal dystropia, a ruler placed at the nasion along with the nasal tip. So in this case, we had this as the horizontal diplopia measurement, dystropia measurement for by keeping at the midline, and then for vertical dystropia and dystrophy. Towards the end, an auscultation with using the Bell of a stethoscope becomes very important to in all cases of AV, fistulas, or CCS to look for any gushing sound of fluid there. It can be kept even at the temporal fossa in cases with neurofibromatosis. Again, not to forget to do a systemic examination, which is of utmost importance, telling us about cases of neurofibromatosis with neurofibromas, multiple neurofibromas elsewhere, a few lat spots, and freckles. To complete the list of evaluation, imaging is of a very important tool that we have, and being an ophthalmologist, where we are quite lucky to have USG B/A scan to our handiness, and we get to know about the solid versus cystic nature of the lesions. And an ultrasound B scan, you can also see a calcified lesion if it's in the case of cysticercosis with high amplitude spikes. And it's also very helpful in cases with cavernous hemangiomas in adults where you see the typical dancing spikes. But we can't get away this by doing an ultrasound. Imaging requires the CT, a contrast enhanced CT, where you suspect any bony changes. Otherwise, a contrast enhanced MRI helps us in working up of tumor with any extension into intracanal space and synovial space. Thank you so much. I invite all of you to the 6th Biennial World Conference of the CCD 2025 happening at our place in November. Thank you so much again.
Thank you so much, Dr. Sal. That was a very comprehensive talk covering all the aspects of proptosis. I just had one question for you. How do you document proptosis in children? How do you monitor the progression or regression of proptosis, especially in children? And is it just based on clinical photographs, or is there something else that you do for patients who are not cooperative for hurtles or who have huge abaxial proptosis? I think Dr. Sahil got disconnected. Dr. Swati, would you like to answer that?
Yeah. Okay, thanks, Ayushi. Yeah, first of all, I think Sahil's talk was very informative. It's, of course, very challenging to do Hurtle's exophthalmometer in children, especially in very young children. It becomes even more difficult. Wherever it's in slightly older children, yes, that's an objective way to measure the reduction in the proptosis as well with treatment. But in very young children, probably we'll have to rely on the clinical photographs more than the objective measurement with Hurtle's. But and also if we are dealing specifically with tumors, I think imaging after treatment also helps us to know if there is any residual lesion which is causing proptosis or not. So based on individual case, we will have to see how to monitor the proptosis in each case.
Okay, thank you. I think Dr. Sahil will join in a while. So now I invite my mentor who has taught me the A to Z of oncology, be it the orbit, eyelid, surface, or intraocular. Dr. Swati Kaliki will be talking about the several case scenarios of pediatric orbital tumors. And over to you, Dr. Swati.
Yeah, thanks again, Ayushi. First of all, thanks to you and Saurabh for making me a part of this program. I'm just sharing my screen. I hope you're able to see my screen.
Yes.
Let me just go to presenter. Sorry. 1 second. It's not in presenter mode, right?
Just
No.
I wrong.
Yeah. Okay. Is it full screen now?
Yes.
Okay, a very good evening to all those who have joined. Welcome back, Sahil. I think there was a question that Ayushi had, but yeah, maybe if you want to add to it now or later, whatever. Ayushi, what do you?
Were you able to hear the question, Dr. Sahil?
No, I think, light went off. I was working on my desk. If you could just get back to the question.
Yeah, so I was asking, how do you document proptosis in children? Is it just based on clinical photographs, or is there anything else that you would
More or less,
personally
we
do?
tend to do a frontal profile photographs in all the children, so that serial documentation is there, and the visual acuity examination, and along with some extraocular movement examination, tells us about, especially in cases of orbital cellulitis, how the child is responding.
Okay. Thank you. Dr. Swati, you can continue.
Yeah.
Sorry
Okay.
for the interruption.
That's fine, Sahil. Okay. So let's continue with, I'll take you through few case scenarios, I think, because I always believe that case scenarios are the best way to learn about the nuances of, like, whatever we are trying to teach you. I do not have any financial disclosures with this talk, and full face photographs will be shown with certain cases, and due permission has been obtained for the same. Let's start with case one now. So this is a young child, a 5-year-old girl who presented with to the emergency with history of pain, redness, swelling, and proptosis of the right eye for the past few days. And there was, and if you notice, almost always the parents give a vague history of trauma. In any case that they come with, they always attribute it to trauma, and that's what happened in this child as well. And there was absolutely no history of fever that was present in this child. This child also had been treated as orbital cellulitis elsewhere, and then was brought to us. So is that diagnosis correct? Is something that we have to think about. It's a 5-year-old girl and has these unilateral symptoms. Yes, of course, if they can have, or orbital cellulitis can certainly present like this. But on best corrected visual acuity testing, the child had absolutely no vision in that eye. And of course, you see the signs of inflammation that are present. That is lid edema, chemosis that is present. That's very obvious from this picture. They were also carrying this a CT scan. They came along with the CT orbits, and you can see here that the paranasal sinuses are clear. So if it were to be orbital cellulitis, most of the times these children have the paranasal sinus fullness, which is contributing to orbital cellulitis, which is not happening in this child. And if you look more carefully, there is something inside the right eye, and not just in the right eye. If you carefully look, there is also something that is present inside the left eye as well. Nasally, if you see that, there is some hyperdensity that is present within the eye. And when we did the B scan in this child. Now B scan, obviously it gives out more information here in this child, where you can see that there is an intraocular mass that is present and there is calcification. If you see the lower left scan, there is that hyper reflectivity area that is present, which is causing some amount of shadowing as well. So definitely this is not a simple case of orbital cellulitis, but it is a case of bilateral retinoblastoma with orbital pseudocellulitis in the right eye. So always, especially in very young children, when they present with cellulitis or cellulitis-like picture, do not forget to do imaging either in the form of ultrasound orbit, or you can get CT or MR, preferably MRI, if you're suspecting retinoblastoma, to have a clear-cut diagnosis. Because obviously the treatment in these cases, it is completely different than an infective cellulitis. So in this child, you would go ahead with bone marrow and CSF analysis. Then you do not need to give antibiotics in this child. You just need to give IV steroids for about 48 hours, and then the edema subsides. Once the edema subsides and we make sure that there is no extraocular extension that is present in the right eye, we would go ahead with enucleation and implant for the right eye. And of course, the child will need treatment for the left eye because it's a bilateral tumor. So that's what we did for this child. This child underwent enucleation of the right eye after steroids and received chemotherapy to salvage the left eye. And this is the child after enucleation and enucleation that was done on 6 cycles of chemotherapy with the prosthesis that has been fit in the right eye. So the important take clinic message from this case is that orbital or ocular imaging is mandatory whenever fundus examination is not possible in children, which might be the case in most of the children because they're already in pain or they have this stranger anxiety and they wouldn't allow you to do a fundus examination. But doing an imaging is not difficult in these children, and that is very, very important to be done. Now, let's move to a second case scenario. Now, this is a child, a young child again, a 1-year-old girl who is brought into the clinic with history of redness, swelling, and proptosis of the right eye. Again, there was a vague history of trauma that the parents were giving. There was no history of fever. This child again was treated as orbital cellulitis. This child had received IV antibiotics, oral antibiotics, everything, but still the child had this persistent redness that is present. Now, when we do imaging in this child, you can see that there is something that is present in the orbit. Again, if you see the paranasal sinuses, the ethmoid sinus, obviously you can see, and the sphenoid sinus, they are clear. There is no fullness that is present. But there is an ill-defined lesion, that is space-occupying lesion, that is present in the right orbit. Left, you can see that it is absolutely normal. But in the right, there is definitely something in the orbit. And this is the on contrast of the same scan. So here you can see that there is intense contrast enhancement that is present. Now, when there is such intense contrast enhancement, you know that this is a vascular lesion. So that is what this child had. This child, in fact, had periorbital hemangioma, infantile periorbital hemangioma on the right side. And this child just required simple medical treatment. We went ahead and gave propranolol. The protocol that I follow is first I start the child on 1 milligram per kg body weight for 1 week. Make sure that the child is tolerating the dose of 1 milligram and then escalate the dose to 2 milligram per kg body weight from week 2 and then continue the treatment till the desired effect is obtained. Then again, the important point here is two important points rather. I always tell the parents to get a pediatrician review every fortnight just to make sure that the child is not having any tachycardia or any respiratory symptoms because of the ongoing treatment with propranolol. And of course, you have to make sure that the child does not have any underlying cardiac disease or respiratory illness before you start propranolol. And once the desired effect is seen, it's very important that you do not suddenly stop the treatment. Rather, you have to slowly taper the treatment, just like how you do with steroids, and then you gradually stop. So slow taper and stop is very important. Otherwise, these children will have rebound phenomenon. The moment you stop, then again the swelling comes back. And that's why it's important to slowly taper and then stop. So this is the same child where you can see that the lesion has completely disappeared and the child has no proptosis. The eyelid redness that you saw in the first picture is completely gone and is doing well. Now this can be applied even for extensive lesions such as this. Now here you can see that the child has some amount of proptosis on the right side and has extensive cutaneous component, which is mostly on the right half of the face. Now these children, again, this is the imaging which shows that there is an orbital component which is responsible for proptosis. And of course, there is even the cutaneous component that the child has. Now this is the same child after a few months of treatment. I think this was after 3 or 4 months of treatment, where you can see that the proptosis has reduced. And even the cutaneous component, there is significant difference that is there before, if you compare to the picture that I showed before. Now coming to case 3, now this is a child. Now here a 4-year-old girl was brought into the clinic with complaints of proptosis and severe pain in the left eye for the past 3 days. So note that the history is of only 3 days in this child. There was no history of trauma or fever. Now this is the imaging that you can see here. Again, there is a ill-defined infiltrative lesion, but it is a heterogeneous lesion. It's not purely homogeneous. You can still see some hypodense spaces that are present in between. And here it appears as though even the superior orbital fissure is slightly widened as well. I do not have contrast image of this child, But of course, this is now, if you go back and ask the history, specifically the history to the parents, that did the child have any upper respiratory tract infection recently? Most of the parents would say yes, that the child might have had like upper respiratory tract infection, and that's why this has just like such short course of only 3 days. This case was in fact just a simple left orbital venolymphatic malformation. It was not any malignant lesion or anything, though it was a very short history. And in this child, you would simply have to do sclerotherapy with bleomycin. You do not have to do an incisional biopsy to confirm the diagnosis. Of course, if you're uncertain of the diagnosis, then you just do an open technique, like you just open the orbit, see the lesion, and if it is very obvious, like VLM, you just go ahead, like no lymphatic predominant VLM, you just go ahead with sclerotherapy. If you're not convinced that it is VLM, then you just do an incisional biopsy. Now, in this case, we made a clinical diagnosis. We went ahead and did sclerotherapy with bleomycin, and this is the result. And you can see that the proptosis has completely regressed, and the child is doing fine. Ayushi, you can let me know if I am overshooting my time. I can stop
Oh,
there.
Dr. Swati, please continue.
So coming to the next case, now this is a child. Again, you can see that there is obvious proptosis that is present on the right side. This is a 7-year-old boy who presented with proptosis of the right eye for the past 25 days. Also note that the child has simultaneous symptom of fever, which is on and off since the same 25 days. Here, there was clearly no history of trauma, though you see like an abrasion that is present on the left side. Probably it's just a nail scratch or something. The parents didn't give any obvious history of trauma in this child. On examination, of course, the vision was okay for the child, 20/40 in the right eye and 20/20 in the left eye. And on, you can see that fullness that is present in the upper lid, and there was a firm palpable mass that was present that we could palpate through the upper lid in the right orbit. Now, this is the imaging of the child. So here you see that if you compare to the previous scans, you see a very homogeneous mass that is present in the lateral orbit, which is causing indentation of the globe as well laterally. And if you carefully see, there is also a lesion on the left side. It's not just limited to the right side, though the child has obvious proptosis on the right side, obviously because the lesion is larger on the right side. But you do see that very similar, homogeneous, almost symmetrical, but smaller in size lesion is present on the left side as well. Now, whenever you see a homogeneous lesion in a child, the first diagnosis that should come to your mind is that of granulocytic sarcoma. So that's what we suspected in this child, that this, because also if you remember, the child also had history of fever, which was on and off. So we came to a diagnosis of bilateral granulocytic sarcoma in this child. Now, what would you do? Do you want to do an incisional biopsy? That is a call that you have to take. Now, if you're suspecting granulocytic sarcoma, you really do not have to do an incisional biopsy. The first thing that you do is just go ahead and do a peripheral blood smear. So that's what we did in this child. So peripheral blood smear did show that there are blasts that are present in the peripheral blood smear. That gives away your diagnosis that definitely this is a case of granulocytic sarcoma with the systemic involvement, and you do not need to do an incisional biopsy to prove that it is granulocytic sarcoma, because this child obviously will need treatment with a general oncologist, and we would just refer the child for treatment to a general oncologist, where of course they will have to do a bone marrow biopsy and everything to confirm what type of leukemia it is to start the treatment. So this child in fact had acute leukemia. So the pearl that you need to learn from this case is, whenever there is a rapid onset proptosis, 25 days is rapid onset. So whenever there is rapid onset proptosis with bilateral soft tissue homogeneous lesion, on imaging, always think of granulocytic sarcoma. And as I mentioned, you do not have to do incisional biopsy. Simple peripheral blood smear will give away the diagnosis. Now let's let's look at another case. Now this is a child who presented with obvious proptosis in the left eye. So there is an abaxial proptosis that is present. This is an 8-year-old boy, and he was diagnosed to have non-specific orbital inflammatory disease elsewhere, and he was also given oral steroids. And then it did not reduce, and that's when the father brought the child to us. Now, on examination, his vision was 20/30 in the right eye and 21/25 in the left eye. And there was a firm palpable mass that was present in the left orbit. Now, look at the scan. Now, this scan, don't you think it looks very similar to the previous case where it is that homogeneous mass that is present, which is extending almost to the posterior orbit? The only difference is that there is no lesion on the opposite side. The opposite side looks fine. It's a unilateral disease. So with this, we arrived at a differential diagnosis of either it's a granulocytic sarcoma. Again, we kept that high on the list because it's a very homogeneous lesion. We also kept a diagnosis of rhabdomyosarcoma because the child was in that age group and it was unilateral. So we kept that also in the differential. Then we went ahead and did peripheral blood smear, but on peripheral blood smear, there were no blasts that were present in this child. So does that rule out granulocytic sarcoma? Maybe. That's what we thought. Okay, so we are not dealing with granulocytic sarcoma. So we went ahead. So we thought, okay, probably this is a case of rhabdomyosarcoma. So the obvious next decision was whether to do incisional biopsy or not. So we went ahead and did incisional biopsy. Now, when we did incisional biopsy, you can see that there are multiple sheets of cells that are present, high mitotic rate, hyperchromatic nuclei with vesicular chromatin, everything that is present, but it does not look anything like rhabdomyosarcoma. Still, to disprove that, we went ahead and did Desmond stain, which was negative, MyoD1, which was negative, which obviously rules out rhabdomyosarcoma, and MPO, that's myeloperoxidase stain, is positive. What does this mean? That means that this patient indeed has granulocytic sarcoma. Bone marrow also was done, which showed a lot of blasts that were present in the bone marrow. So what we thought we ruled out granulosarcoma actually was wrong. This child, in fact, had granulocytic sarcoma itself. So this child had acute myeloid leukemia. Now, the clinical pearl for you to understand is that negative peripheral blood smear always does not rule out granulocytic sarcoma. Of course, when there is a positive peripheral blood smear, you know that it is definitely granulocytic sarcoma, but negative does not rule it out because there is a condition called as aleukemic leukemia, which is present in about 2 to 3% of the cases, where the peripheral blood smear will be absolutely normal. There will not be any blasts that are present in the peripheral blood smear. But when you do bone marrow in these cases, there you will find blasts that are present. And when you do a tissue diagnosis, you will arrive at the final diagnosis. So you should know that aleukemic leukemia can also exist in children. Ayushi, I can stop if I'm overshooting time.
You can continue, Dr. Swati.
Okay, so maybe I think I have another 2 cases. I will go
Sure.
through that then.
Yeah.
Yeah, coming to case 6. Now, this is a child. Here again, you can see that the left eye appears very different when compared to the right eye. The left eye is kind of displaced down, and it is kind of like, there is something that is happening in the lateral orbit. You can see fullness on the lateral side as well. It was a 2-year-old boy. He was brought in with history of painless proptosis since 2 months. There was no history of fever or trauma. Now, this is the CT scan that you can see. And here you can see that there is a heterogeneous lesion that is present on in the lateral orbit, which is extending from the anterior to the posterior orbit. And also you can see that the bony changes are also seen. It's not just the soft tissue changes, but the bony changes as well. So whenever you see bony changes, you always your mind starts sticking as to, oh, probably it's a malignant tumor. Here, in fact, we had a differential diagnosis of Langerhans cell histiocytosis or eosinophilic granuloma, which is a benign tumor but behaves like a malignant tumor, or it could be a PNET, that the primitive neuroectodermal tumor, or Ewing sarcoma. These are the 2 differentials that we had. We went ahead and did incisional biopsy in this patient, and here you can see sheets of tumor cells with eosinophils that are noted. CD68 was positive, indicating that the cells are of histiocytic origin. S100 was positive. Now here the giveaway was the CD1A. CD1A was strongly positive, indicating that this in fact was a case of LCH, or the Langerhans cell histiocytosis, or eosinophilic granuloma. So we arrived at the diagnosis of LCH. So what would you do next? Now, as I mentioned, LCH is a benign tumor, but behaves like a malignant tumor, causing all the bony changes and all of it. Now, so here it's important to do systemic workup for these cases, rule out diabetes insipidus. And if it is an isolated lesion, you can just give intralesional steroids. That's what we did in this child. We went ahead and injected steroids. And to your surprise, you'll see that if you repeat imaging after completion of treatment, the bone will completely reform. So there will be reformation of the bone with treatment. Whenever there is multifocal involvement, of course, you will have to do systemic chemotherapy in these cases. So this child received 6-weekly intralesional steroids, and this is like the post treatment results. You can see that the proptosis has reduced, the mass that was present in the lateral orbit is completely gone, and the child is doing well. This is another case of LCH itself, but I just want to show you this because this child behaved differently. Now here you can see that the right eye is proptosed. It looks different when compared to the left side. It is slightly displaced downwards as well. And this child, if you see the CT scan, the lateral orbit, it appears similar to what you saw before, where there are bony changes. But if you see the skull, it's a multifocal lesion. It's not a unifocal lesion. You see the top, you can see that there are the bony changes that are present there as well. So whenever it is multifocal lesion, you cannot just do only intralesional steroids. These children require systemic chemotherapy. That's what we did in this child, where the child received oral steroids and in addition also received systemic chemotherapy. This is the child after, I think we did 1 cycle of chemo. I do not have the recent pictures of this child. I'll finish up with this last case if I still have time.
Yes, Dr. Swati.
Okay. Yeah, so now this is a child, I think Ayushi would be very familiar with this case because she has written a review topic, a beautiful review article on this topic. Now this is a child who presented with proptosis and a mass in the left eye. And again, there was no history of fever or trauma, and the proptosis was only since a year. Please note that this child is only 2 years old. It's not a very old, older age group. It's just a 2-year-old child. Now, on imaging, you can see a very well-defined mass that is present in the orbit. And here, I think it was a straightforward diagnosis given the clinical picture and the way the child presented everything. It was a rhabdomyosarcoma. Whenever you see a case of rhabdomyosarcoma, it's very important that it's not, you have to understand that there are certain conditions where you have to do a systemic workup, and this is one such, where you would do a bone marrow biopsy and also you do a whole body PET-CT to rule out if there is any mets. These children can have mets, especially in the lungs. So it's very important if you're doing a targeted screening, then CT or CECT lungs becomes important in these children. Now, in this child, we went ahead and did excisional biopsy because it was a well-defined lesion. We aimed for complete excision. We did a swinging eyelid approach in this child where we gave a transconjunctival incision. The dotted line, what you see is the transconjunctival incision. And we extended at the lateral canthus and did a swinging eyelid, and we completely removed the tumor. On histopathology, there was a pseudocapsule that was present and sheets of cells that you can see that are the blue colored cells that are present. They're arranged in sheets, had very high mitotic rate. You can see so many mitotic figures that are seen in this picture. Desmin was positive, MyoD1 positive, all supporting the diagnosis of rhabdomyosarcoma. Vimentin again was positive. Now, this was a case of embryonal rhabdomyosarcoma. Again, it's important to know that there are various forms of rhabdomyosarcoma that can be present, and the prognosis, it depends upon what type of rhabdomyosarcoma it is, where botryoid and the spindle cell have good prognosis, embryonal has intermediate, alveolar and pleomorphic have poor prognosis. Most of the times the children do have embryonal rhabdomyosarcoma, which has intermediate prognosis. And now, of course, we are in the era of molecular diagnosis, which I'm sure Ayushi will agree after the review article, that molecular diagnosis is very, very important in these cases to determine the prognosis as well. The treatment, of course, it depends upon if you have completely excised the tumor or if there is microscopic residue, you have to give radiation and chemotherapy. or if there is gross residual tumor, then the treatment will differ. Sometimes we do get metastatic disease as well, where palliative treatment has to be given. This is the child after excision and receiving chemotherapy, where you can see that the child is doing fine. There is no scar, obviously, because we did the transconjunctival approach. But of course, this child did have not a very good course, developed recurrence later, and we had to give multiple sessions of chemotherapy for this child. Okay, I do have one last case. I'll take you through this very quickly. Now, this child was brought into the clinic, in fact, not with the symptom of proptosis, but just for a routine examination. What do you think you see in the scan? The reason I put up this case is that if you see carefully, there are some pigmented macules that are present on the face, the fine brownish spots that you can see. And this is the scan that the child is carrying. Now, here it's very important to understand that when I'm saying hyperpigmented macules that are present, probably it's a case of NF or neurofibromatosis. And the reason I'm showing this scan is that it's very important to do a scan in these cases, because your eyes are drawn obviously towards the right eye because the optic nerve is thickened. But if you look carefully, even the left optic nerve is thickened. The left optic nerve is also not normal. So this child, in fact, has bilateral optic nerve glioma, but right side is more prominent when compared to that of the left side. And if you do a careful examination here, you can see that the child has axillary freckles, has a caffeole spots, which are very obvious. The child even had the iris lesions, everything very obvious, the hypopigmented lesions that the child had on the iris, everything pointing towards the diagnosis of neurofibromatosis type 1. So this child, in fact, has to be treated not just for one eye, but the child has to receive treatment for the other eye as well. And that's what we did for this child. We gave bilateral external beam radiotherapy to the child. So whenever you see pediatric proptosis, you have to take all these into consideration. Consider the age of the child, the laterality of the disease, whether it is acute or chronic onset, whether it is progressive or non-progressive. Always do imaging of the orbit. Systemic screening becomes very important in certain conditions. And whether you need to do an excisional biopsy or incisional biopsy or just medical treatment is sufficient, it purely depends upon your clinical diagnosis. So I think it's very important for you to arrive at a differential diagnosis and then plan appropriate treatment. Thank you very much. And thanks again for this opportunity, Saurabh and Ayushi.
Thank you, Dr. Swati, for the wonderful critical learning points. I wanted to ask you, for what did the patient present to you in the last case? Because he seemed normal other than the spots on his face.
Yeah, so this child, in fact, had come to pediatric OPD just for a routine eye checkup.
Okay.
No anything, and you have this pigmented macules, not many parents would suspect anything. The child was just had just come to pediatric OPD, and they noticed that probably there is something wrong, and the child got referred. So that's how the child ended up with us. But otherwise, the child probably would have presented once the child would have lost vision because of the optic nerve glioma. I think the vision was slightly reduced, not like lost, was slightly reduced, and that's how they ended up in pediatric OPD just for an eye checkup.
Okay. And for the case that you showed of VLM, if you get a dry aspirate in cases where you suspect a venolymphatic malformation, then do you open it up and then do the procedure under direct visualization?
Yeah, I think that's again very important question, because sometimes we do get, especially if it's microcystic, we do get this dry tap. If you are certain of the diagnosis, then I would just go ahead and do sclerotherapy. But when we say dry tap also, most of the times it happens that you just get a little kind of aspirate which just stays at the hub of the needle and not filling the syringe. And if such cases, then I would still go ahead and just inject. But if it is, I'm not sure of the diagnosis, I have just VLM as a differential but not definitive diagnosis, then I would rather just do like an open by, at least I would just open it up. And if it's obvious like VLM, I would go ahead with sclerotherapy, otherwise just do incisional biopsy.
Okay, thank you so much. In the interest of time, we'll move ahead with our case presentation. Dr. Vishali, can you start? Dr. Vaishali is a third-year DNB resident and will be sharing an interesting case of an orbital venolymphatic malformation. We can see your screen.
Okay. Shall I start, ma'am?
Yes.
Good evening, all. I'll be discussing a case of 5-year-old girl who presented to the ophtha. One minute, ma'am. Okay. Good evening, all. I'll be presenting a case of 5-year-old girl presented to oculoplasty clinic with a father with complaint of forward protrusion of right eye since 2 weeks. It was sudden in onset and progressive in nature. However, there was no history of recent trauma, upper respiratory tract infection, or pain. On further probing, her father admitted that this patient had mild proptosis since childhood, but it increased exponentially over last 2 weeks. And these are the photograph of the patient showing gradual progression of the proptosis since childhood. So this she was diagnosed with right orbital lymphangioma elsewhere 5 days ago, for which she was administered IV methylprednisolone 1 gram for 3 days, but there was no benefit noted in the proptosis. Best corrected visual acuity for right eye was 6 by 60, and it was not improved on pinhole, and for left eye it was 6 by 6. Adnexal examination revealed right side abaxial proptosis of more than 25 millimeter. It was painless. There was no pulsation noted. There was no bruit. Vertical and horizontal dystopia was seen with slight superotemporal globe displacement, and also there was fullness noted in the right eye over upper lid with the elevated brow, and conjunctival hypertrophy was noted in the inferior and nasal quadrant. And 3 mm of leg ophthalmos was noted with telangiectatic vessel over the upper eyelid. And in Worm's eye view also, you can see massive right side proptosis. Ocular movement in the right eye was limited in all the gazes, whereas in left eye, it was full and free, and rest of the ocular examination was within normal limit. We advised MRI imaging for this patient, and first image, it is T2 weighted MRI in the axial section, where we can see a diffuse intracorneal lesion with multiple fluid level, and it is also extending in the extracorneal compartment and also involving the orbital apex, abutting the optic nerve. Also, we can see the posterior bowing of posterior globe. This is classic guitar pick sign, which indicate orbital compartment syndrome. And also there is involvement of ipsilateral ethmoidal sinus. On coronal section, also we can see multiple macrocystic lesion, and these findings are further highlighted in T1 weighted MRI in the sagittal section, where we can again see multiple fluid level. Based on these clinico-radiological findings, our diagnosis, right diffuse orbital venolymphatic malformation causing orbital compartment syndrome, was established. And we planned for urgent cyst aspiration with bleomycin sclerotherapy under general anesthesia. So intraoperatively, 13 ml of hemorrhagic fluid was aspirated using 24 gauge needle mounted on 10 ml of syringe, and 6 international unit of reconstituted bleomycin was injected in the inferolateral, superolateral, and inferomedial quadrant. And post-operatively, rapid tapering of oral corticosteroid with combined antibiotic steroid eye drop were prescribed, and patient was then reviewed at 4 weeks, where vision was restored to 6 by 6 and proptosis also reduced drastically. We then planned for another sitting where 6 weeks following the first injection, where 6 ml of fluid was aspirated and 8 international unit of bleomycin was injected. And this is the clinical photograph at 1 month post second injection, where we can see there is further reduction in the proptosis. Before third sitting, we request repeat MRI orbit, where we can see there is marked reduction in proptosis. Angle of globe was also restored, but there is residual intracorneal component with extracorneal component also, mainly in the inferomedial quadrant. And then the patient undergo third sitting where 4 ml of hemorrhagic fluid was aspirated and 6 international unit of bleomycin was injected. And this is the clinical photograph at 1 month following third injection, where we can see further reduction in the proptosis. Then we planned for subsequent surgical debulking via inferior transconjunctival approach combined with 4 international unit of bleomycin under direct visualization. And at her last follow-up, that is 2 weeks following the 4th injection, patient was still having this 4 mm of residual proptosis in the right side. And we are still in our last phase of her treatment and awaiting her final follow-up at 6 weeks following 4th injection. So to summarize, our patient did with right, hello?
Yes, you're audible.
So to summarize, our patient presented with right side orbital compartment syndrome following orbital venolymphatic malformation with abaxial proptosis of approximately 24 millimeter, for which she underwent 4 injection of sclerotherapy and 1 sitting of orbital exploration, and after which proptosis was markedly reduced to 4 millimeter, vision was restored to 6/6, and globe angle was also restored. So with this, I would like to ask our guest faculty, Dr. Swati ma'am or Dr. Sahil sir, what would they consider as the endpoint of treatment in this case?
Yeah, first of all, very well presented, Vaishali. Yeah, so these cases, I think, I would not aim for, the complete, the eye going back to the normal position, like the opposite eye. Maybe that will not be the aim in all cases. Yes, that can happen in most cases. Especially if it is like, sometimes you would see that when you do imaging in these cases, even the orbit might have enlarged, especially if it is like long standing cases and all of it. So in those cases, you can never get the globe to go back to the size of the normal eye. So that may not be the aim, but if there is significant reduction, I would say, say 90% reduction that is present. I'm not aiming for, okay, that there should not even be 1 microcystic component that is present. That may not be the aim. Most of the cases, I would say I would stop at 3, or maximum I would go to 4, depending upon the response. I do not remember any case where I have gone beyond 4. So if there is good amount of reduction, say about 90 to 95% of the reduction that is there, then I would just stop there. Also, we have to understand that sometimes, the fibrosis, the changes because of fibrosis, it might take time, though you might see that there is still that residual proptosis after the third injection. If you see the patient after a few months, the eye would look even better after a few months. So I think you have to give some time as well. So that would be the answer for that part of the question. What is the end point? Do you want me to take other questions, Ayushi? How do you want?
So in this case, like the patient and the father are not affording and they are actually satisfied with this outcome. But objectively, we know that the eye has not reached within 2 millimeters. So that is the dilemma here. And that is why we wanted to ask you.
Yeah, so as I mentioned, I wouldn't kind of push too much if they are not too concerned about slight residual proptosis that is there. I would observe for now. And as I mentioned, after a few months, you would see that the proptosis might have decreased a little more. Not that there will be drastic change, but it might decrease little more. Having said that, also they have to understand that these children can still have recurrences. That can, of course, can still occur, because we have seen children where they are okay for 2 years, 3 years, and then they can come back with recurrence. So recurrence also can occur. But for this child, I think it's satisfactory result. And you've already done 3 injections, right?
4.
4 injections. Yeah, 4 injections. So I would.
The last was a combined sitting of surgical debulking and the injection. But when I was doing the surgical debulking, it was all fibrosis.
Yeah,
So
exactly.
on retraction, actually, the pupil was getting dilated because I think there was so much of fibrosis that it might have pulled the optic nerve or something. So it was a very difficult thing to do.
Yeah, I think especially like, if there is so much of fibrosis, even your further injection may not really help much because ultimately all these sclerosing agents are causing fibrosis. So if you are just injecting into the fibrotic tissue, there will not be further change. So if you have opened it up and seen that there is just fibrosis that is there and there is residual proptosis, I would just observe. I wouldn't go for further injections in this case.
Okay. And the other thing was, if you're suspecting a vascular anomaly, what is your indication of doing a color Doppler to rule out an arterial component?
Yeah, so in general, we do not use color Dopplers so much, at least in our practice. But I know that there are practices where they use color Doppler as a significant imaging modality for diagnosis. We would rely more on MRI with contrast. We do not use so much of color Doppler, but of course, like no color Doppler also is a modality. If you are not able to do an MRI with contrast, then of course color Doppler definitely comes into play.
Okay. And do you have any experience with sirolimus? Because I was thinking, what if we keep this child on sirolimus thereafter? And I also wanted to know the cost efficacy of sirolimus for these patients.
Yeah, so I have not, personally, I have not used sirolimus in these cases, but yes, there are like, if you look in the literature, there are enough reports which support that this is effective. In fact, in the chat box, I saw like, question of an alternative sclerosing
Equivalent.
as well. Correct.
Yeah.
So there are like numerous sclerosing agents that are now available in the market, and all of them are definitely effective. Though we say that like, the textbook descriptions, like for example, even bleomycin, the textbook description would be that it is useful only for macrocystic. Now, but of course, we have seen practically that it is useful. It acts well even when it is purely microcystic as well. The same thing with other sclerosing agents as well. So it can be used for either macrocystic, microcystic, or a combined like lesion as well. And sirolimus, as I mentioned, I do not have personal experience, but whatever I have seen in the US and whatever I have read in the literature, definitely it is helpful. I really do not know about the cost in India because I haven't used it, so I haven't explored about its availability or the cost.
Okay, thank you so much, Dr. Swati. We'll move on to Dr. Manisha's case. Dr. Vaishali, can you unshare? Yes. So Dr. Manisha is our second year DNB resident and will be presenting a case of an orbital dermoid cyst. We can see your screen, Manisha. You can continue.
Good evening, everyone. Today I'll be presenting a case of 13-year-old boy student who came to our OPD with complaints of swelling in the inner corner of the left eye, which you have noticed from the past 3 months. It was painless and gradually progressive. Patient also gives a vague history of trauma 6 months back. No visual disturbances were present, no watering, bleeding, or any discharge from the swelling, and there was no prior episode or any surgeries. Best corrected visual acuity in both the eyes was 6/6. And on adnexal examination, both vertical and horizontal dystopias were noted with the 3 mm and 4 mm respectively with infralateral globe displacement. Superomedial fullness with palpable mass is also noted, which on palpation was a firm, non-tender, ill-defined mass. It was mobile, but the posterior extension of the mass could not be delineated. The overlying skin was normal and there were no signs of any inflammation. On Hertel's examination, 2 mm of abaxial proptosis was noted, and here in this warm sea we can see the lateral displacement of the globe. Ocular motility was full and free with the limitation in dextro elevation. Rest of the ocular examination was with a normal limit. So at this point, our differential diagnoses were left eye orbital rhabdomyosarcoma, orbital dermoid cyst, hydatid cyst, frontal sinus mucocele, orbital VLM, and meningoencephalocele. To further pin down our diagnosis, CT orbit with soft tissue window was ordered, and this is the axial view where we can see a very well-defined hypodense lesion with hyperdense margin. It is extending till the mid-orbit. It is extragonal, and it's also abutting on the medial rectus muscle, and there's a lateral displacement of the globe. This is the coronal view where we can see a mixed density lesion. Upper 2/3 is hyperdense and the lower 1/3 is isodense, which is the hemorrhage about which the patient also gives a history of awake trauma. And here we can also see the bowing of the medial wall, which is suggestive of the chronic nature of the lesion. So based on our clinico-radiological diagnosis, left eye orbital dermoid cyst was made, and the patient underwent transconjunctival orbitotomy via transcaruncular incision with excisional biopsy under general anesthesia. Intraoperatively, a very well-defined mass was excised in toto. It was measuring 2.2 centimeters in length and 1.5 centimeters in width. Surgery was uneventful and the specimen was sent for histopathological examination. This is the histopathology slide, H&E staining, 10x, showing stratified squamous epithelium lining the cyst. This is the keratin debris, and we could see the sebaceous gland lobules also. There were few elements of sweat glands and hair follicles which are not visible on this slide. So this with the histopathological evidence, the diagnosis of orbital dermoid cyst was made. So postoperatively, the postoperative follow-up, the patient had as we can see here, the proptosis have resolved entirely, and even the dystopia has resolved, and the patient was doing functionally and cosmetically good. As we know, orbital dermoid cysts are not uncommon, and imaging is a very crucial entity to rule out subperiosteal extension and dumbbell morphology. Management of choice is surgery with excisional biopsy. But however, in recent days, foam sclerotherapy for periorbital dermoid cysts have gained wide attention. So here I would like to ask Dr. Sahil and Dr. Swati ma'am for with their experiences with foam sclerotherapy, and are there any specific indication for the same?
Yeah, thanks, Manisha. Yeah, I think now dermoid cyst in pediatric and adolescent age group is a very common condition that every oculoplasty surgeon comes across. So it's important to know when to intervene and what form of treatment should be offered to the patients as well. Now, I think one thing I would just add a few points before I answer these questions. It's important to know that as the patient's age increases, the chances of the dermoid cyst causing the other orbital changes, not just like, the indentation and all of it, the fossa formation, which is pretty common, but it can also cause kind of the so much of bone remodeling that there will be resorption of the bone. It's not lysis, but there will be resorption of the bone that can occur. Sometimes so much so that it is like, you would see, especially if it is present in the superior orbit, it's just that you'll see a dural lining. The entire, the roof would have resorbed because of the chronicity of the lesion, and it would just be in touch with the dura. So it's that is why it is important that these lesions should be excised during childhood or adolescence, and not wait till the patient is like 30 years or 40 years, saying that, okay, this is only a benign lesion, you don't have to do anything about it. That may not be the situation in every case. Yes, when they're very small, yes, you can observe, but when they are slightly larger in size, it's better to excise. It's better to treat them. I wouldn't say excise always. It's better to treat them. Now, what foam sclerotherapy, as you showed, yes, that's a form of treatment that is available. Would I do it in cases where I can go ahead and easily surgically excise? Probably no. If it is easily surgically accessible, my treatment of choice would still be excisional biopsy. Where would I use foam sclerotherapy is these cases, like, what I had like not recently, about like 4 or 5 years back, I had a patient who was doing her medical school at that time. And she noted that her eye was kind of like, looking different. And she came at the age of, I don't know, 20 or 21 years old. And when we did imaging, that patient had dermoid that was present in the lateral orbit, and it was dumbbell shaped, and it was extending into the temporal fossa, and it was like, it had significant extension into this temporal fossa, and there was no way that we could completely excise it in one piece. Even if we kind of like, go to excise, it was like, extending so much that even if we extend the incision, um, definitely there will be some remnant of the wall that will be left behind. You cannot remove it as a single piece. So in such cases, definitely foam sclerotherapy helps when you are not able to when you know that you cannot completely excise. At least you can do foam sclerotherapy so that you cause destruction of the cystic wall, so that the chances of recurrence is less. So in such cases, probably I would choose foam sclerotherapy. But wherever I can excise, my treatment of choice would still be excisional biopsy. And for the second question about what would the approach be towards dumbbell dermoids, yeah, so dumbbell dermoids, again, like, long-standing dermoids sometimes can have the dumbbell component. As you can see in the picture here, there is a small component of the extraorbital component that is present. Now here, in these cases, it's very, very important that you remove the entire cystic wall. Here we have to understand that there is no way that you can remove the entire cyst without rupturing it, because a component of it has gone through the bone to the extraorbital portion as well. So it is going to rupture. The cyst is going to rupture. So when I know that it is going to rupture, what I would rather do is just like, aspirate the contents that are present inside and try to remove the entire cyst wall. The cyst wall that is present in the bony part, like, through the bone, in that I would like, even sometimes use cautery just to make sure that whatever are the remnants of the cyst wall that are present are kind of like, are destroyed by the cautery, and ensure that the entire the cyst wall is removed.
Thank you, Dr. Swati. So this was actually a 35-year-old lady who presented with this imaging. The drill that we have is the one that we use for the endoscopic DCR, which has a maximum RPM of 12,000. So initially we planned for drilling this piece out so that we can put completely excise it. Of course, it ruptured, as you said. But then since drilling was not possible, what are the other things that we can do? So do you recommend going externally from the other side? Because what we did is we removed this entire wall, but the infratemporal fossa component was actually cauterized, and we applied absolute alcohol over that area so that any remnant does not grow back. So would you recommend going for an external approach and then dealing with it in cases where we don't have the orbital drill?
Yeah, I mean, most of the times you don't need like, you just need to extend the incision, like whatever, like, say if you're taking the lid crease incision, you might have to extend it beyond what you would just use only to deal with the orbital component. You might have to definitely extend the incision. And as I mentioned, just like, we have to ensure that the complete cyst wall is removed, and that has to be done under direct visualization. We have to ensure that the incision is extended to the extent that you're able to see that component. And only then, after I see the entire extent, only then I would do the further dissection of the lesion. Because if you're not seeing the entire extent, and then you see the majority of the intraorbital portion, and then we start dealing with it, it will rupture, and it will be very difficult for you to kind of delineate the remaining, the remnant of the cystic wall. So I would first visualize the entire lesion, and then kind of like, go ahead with the surgery. Yes, if you have a drill, of course, like, that helps you kind of to make sure that you're not leaving behind any remnant of the cystic wall. But most of the times what happens is these are like, these, as you can see, even in this case, it's quite deep seated. So it's not easy to use. It's like, we can say, okay, use drill. But when it is deep seated, practically when you have to apply it, it's not easy. If it is like, if it is very anterior, it becomes easy. But when it is deep seated and very posterior, it becomes difficult to use the drill as well in these cases. So wherever possible, yes, I would use it. And especially these cases, using the drill from the other side becomes like, it's more easier. Like from the extraorbital portion, if you use it, it becomes more easier than trying to go from the intraorbital portion.
Right. Thank you so much for patiently answering all our queries and sharing your expertise. I wouldn't have spent my teacher's day any other way. So now I would like to request Dr. Nidhi to announce the quiz and also give her vote of thanks.
Thank you. Thank you, ma'am. It was such an extensive master class where everything was covered, starting from the basics, where Dr. Sahil covered all the examination techniques and the basics of the proptosis. And Dr. Swati ma'am's presentation will go into the library of Nandadeep, where anyone who wants to read on the pediatric proptosis and especially the oncology part, they have to see that first so that reading the book becomes easier. And also, I would like to thank Dr. Ayushi for taking this initiative, and she spent a lot of time with the students to refine their presentation and made them study. Thank you, Dr. Bhavagnya, for arranging the quiz. And thank you, the students, Dr. Manisha and Dr. Vaishali. They have done a lot of hard work for this presentation. Thank you for all the attendees. And still the highlight of this webinar is still there. So I will request every one of you to go to the chat box. There is a Kahoot pin. And if you want, you can download the Kahoot app also. Otherwise, in the screenshot, if you direct your camera, then also you can join it. And the pin is the 783200. If you have the Kahoot app, you can put the quiz pin 783200. Or otherwise, you can open the screenshot and then it will show the QR code. So there will be 15 questions and there will be prizes to be won. 3 prizes are there to be won. So I'll request everyone to join it. Dr. Bhavagnya, are we ready?
Yes, ma'am. I am waiting for the participants to join. I hope all
you
the
can
attendees are
share
going
on
to
the
join.
screen the QR code. It will
Yeah,
be easier for them.
I'm doing
and
that.
Right. Yes. If anybody is facing any problem in joining, they can message in the chat box.
In the chat box, there is a link, so they can click on that.
Yeah.
And then add the code.
So I think there are 29 attendees.
I hope all of you are able to see my screen. I hope all the attendees have heard the talk because the quiz is all filled with the information from the talk. So I'm sure those who have been attentive will skim through it very easily. And there are amazing Amazon gift card prizes to the top 3 winners. Shall we start the quiz, Dr. Ayushi? Or shall we wait for a
Yes,
couple minutes because I see the
How
number
many do we have?
increasing.
19.
Yeah, we have the number increasing going on. So shall I wait for a minute or so?
Yeah, I think we can wait for 1 minute. 7:19, so we can wait till 7:20.
If any attendee is facing any difficulty, they can message. You can basically direct your camera directly to the QR code, zoom it in.
Nidhi, it's not possible to direct camera. They are connected by mobile. So
Okay.
I have given the link. So they have to click on the link and add the code.
I think we can start. We have
Yes.
18 people.
Okay, sure. I'll start the quiz then. Now, this is a question where you have to type the answer. It's pretty simple. This is just a starter for you guys. I'm sure those who have attended or heard Dr. Manisha's presentation would answer it very quickly. So the second question, this is a multiple choice question. So you have a 4-month-old girl presenting with a pink mass in the right upper lid associated with ptosis, which increases when the child cries. What is the most likely diagnosis? So when you have Cruzen syndrome, what's the classical triad? Someone who has heard Dr. Sahil's class again can pick it up very quick. So these are our scoreboard with the top 3 contenders. The next question, we have a 40-year-old male with left eye intermittent proptosis, which worsens on straining. He noted a reddish lid mass, which was non-pulsatile and increases on bending forward. What's the probable diagnosis? Okay, this is a stumper. This is just a regular oculoplasty. Which of the following imaging techniques is shown in this form of lacrimal imaging? And there's been a recent article which has been published by Dr. Ayushi Agarwal on this imaging technique and her experience with a case. So we have an 8-year-old girl with right eye painless gradual proptosis for the last 2 months. On examination of the right eye, we notice the vision is 6/60 and there's an RPD present. The child has in general examination leash nodules. So what's the most likely diagnosis? There was an interesting case discussed by Dr. Swati. Another stumper. For those who know their anatomy good, you will get this. The inferior oblique muscle lies between which two orbital fat pads? We see Dr. Akash and Pooja on the top. Weber-Mason syndrome results in proptosis due to Akash is still leading. So this is a clinical scenario again. A 32-year-old male who gives a history of sudden fall from ladder and presents with sudden onset painful left eye proptosis and ophthalmoplegia. What is the most likely diagnosis? The clinical picture gives a lot of clinical findings, ocular clinical findings. So you have a stumper again. Which of the following is a risk factor for the condition shown in the picture? So which of the following is the most common intraocular tumor in children? So which of the following is not true about the Hoyt-Spencer triad? So it's an answer that you have to type for the question. A 5-year-old boy presents with left eye rapid painless swelling post a trivial trauma. On examination, we notice proptosis with ocular motility restriction. There's lid edema, conjunctival congestion. What's the probable diagnosis? Another stumper on the way. Which is the most common organism causing canaliculitis in the Indian subcontinent? Akash is quite in the lead. To the last question. A very clear-cut question. A 7-year-old child who gives history of recurrent unilateral proptosis, which is usually seen post a minor trivial upper respiratory tract infection. What is the most likely diagnosis? So here to the winners. Congratulations, Dr. Akash. I think you have enormously been unanimously elected as the winner here. And I hope SRB is Dr. Saurabh sir there. And Dr. Pooja, all three of you, please leave your messages or mail ID with us, and we'll connect back with you for your gift card that we would share as prize winners. So the third prize winner would get an Amazon gift card worth rupees 500, and the second would be getting 1,000 rupees gift card, Amazon gift card, and the first will be getting an Amazon gift card of 1,500, which you can add it to your Amazon Prime account, and it expires after a year. I hope it was a very good quiz session. I hope you took out learnings from your talk and applied it here.
Dr. Pooja has shared her phone number in the question and answer.
Okay, ma'am. Can I have the second and the third winners also, please?
Dr. Pooja, can you share where are you from and your introduction? And Dr. SRB, Dr. Saurabh, if he is there, and Dr. Akash. You can message also your full name and where are you from. Okay.
They have.
Okay. SRB is Dr. Shazia.
Okay.
Congratulations, Dr. Shazia, Dr. Pooja, and Dr. Akash.
Okay. So, Dr. Aishi, I think we can close this session.
Yeah. Dr. Akash, can we get your number or any contact detail to send?
I think we'll have it in registration.
Yeah. Just to
Later.
verify if that's the same.
Okay.
Dr. Nidhi, would you like to say any words to conclude the session?
Yeah, actually we have finished only. I had given the vote of thanks, so we can finish this. And it was a very useful session, but I would like to know the feedback of the attendees. It will be very useful for us, whatever changes they would like in the future sessions from a perspective of a student or a fellow, and what new topics that they would like. And it was a very useful session, I felt, in the terms that it covered the basics also and actual practical aspect from a very world class teacher. And I understood why you like oculoplasty oncology that much, because Dr. Swati's presentation and case scenarios were amazing. I mean, if any student who just goes through her presentation again, it will the 5 hours of studying can be commenced into a very short time, and you will be interested in learning and you will remember it for a long time. So thank you, Dr. Ayushi, for getting in contact with all both of these mentors who were really very useful for all our students.
Thank you so much, Dr. Nidhi, for this opportunity. And Dr. Saurabh, would you like to say anything?
Yeah, thank you so much. It was very nice session, and I could see that all the delegates participated also. And we'll definitely come up with more sessions which are useful clinically as well as for our postgraduate students.
Okay.
Thank you. And
I
thank
would
you
like
for
to just add a last bit of thanks to our digital team at Nandadeep Eye Hospital. They have been working really hard to get the net and my quiz going on at the right time. So to Mr. Rishikesh and Suraj and Miss Shruti, thanks to them to having made this successful. They've been very vehemently sitting to make this a good success.
Oh, really? Thank you. Thank you, digital team.
Thank you. Thank you, Manisha and Vaishali, for the wonderful presentations, and Dr. Bhavagnya for co-organizing this session and making sure that everything is seamless. Thank you.
Thank you, everyone. Good night.
Thank you.
Good night.